All right, let's jump right in. Today, we're going to unpack a really important topic, one that touches millions of lives: colorectal cancer. We're going to follow the entire journey here, from the very first potential warning sign all the way to the modern solutions for fighting it. So, where does a story like this even begin?
Well, it almost always starts with a question your own body might be asking you. What do you do when something just feels off? You know that feeling? That's our starting point. It's a journey that really begins by just listening to those crucial first signals.
Okay, so let's get into it, the first signs. Colorectal cancer often doesn't just show up and announce itself with a marching band. The clues can be really subtle. And, interestingly enough, they can change a lot depending on one key thing: exactly where in the colon it is.
It's pretty fascinating, actually. The anatomy of your colon plays a huge role in what you might feel. So, think of it this way. The left side of the colon is narrower. A tumor there is kind of like a rock in a small pipe. It's going to cause a blockage pretty quickly. That means more obvious signs like bleeding or, changes in bowel habits. But the right side, it's wider. So a tumor there can grow for a while without causing much trouble, making the signs way more subtle. So subtle, in fact, that in an older person, it can sometimes mimic something totally different, like appendicitis. Wild, right?
So what are we actually looking for? Well, some of the most common red flags are things like any kind of bleeding, mucus discharge, or that really persistent feeling like you just can't completely, empty your bowels. And in some situations, if a tumor is in a specific spot, it can even affect the sphincter muscle itself, which can lead to issues with control. Look, these are serious signals. They're messages from your body that you really, really shouldn't ignore.
All right, so let's say someone notices these signs and goes to the doctor. What happens next? This is where the investigation really kicks off. Doctors have a very clear step-by-step process to figure out exactly what's going on, starting with simple screenings and moving towards a final diagnosis.
This whole diagnostic journey is super methodical. Step 1 is often pretty simple: stool tests that can look for tiny amounts of blood you wouldn't see, or certain antigens. But Step 2, that's the gold standard: the colonoscopy. This is where a camera gives doctors a direct look inside. It's the most definitive way to know. And if they do find something, we move to the absolutely critical third step: staging. This is all about figuring out how far the cancer has progressed.
And the tech they use for staging is just incredible. Think of it like a camera with different lenses. For a super close-up view, to see exactly how deep a tumor has grown into the colon wall, they use something called an endoscopic ultrasound, or EUS. It gives the sharpest local picture. But for the wide-angle shot, to see the bigger picture of the whole pelvic region, an MRI is the way to go. Each tool gives doctors a crucial piece of the puzzle.
So what about a simple blood test? You might have heard of something called the CEA marker. And yeah, if those levels are high, it's definitely an indicator, a clue. But, and this is super important to understand, it's not a definitive diagnosis by itself. Think of it as another piece of evidence in the investigation, but it's not the smoking gun. Okay, a diagnosis is confirmed. What now? This is where we shift from investigation to action. And modern medicine has a whole playbook for this. The key thing to remember is it is not a one-size-fits-all approach. It's a completely customized strategy, tailored to the exact situation.
And one of the smartest plays in that book is something called neoadjuvant therapy. It sounds complicated, but the idea is actually really clever. Instead of jumping straight into surgery, doctors might use chemo or radiation before the operation. Why? To shrink the tumor. This makes the surgery itself easier, safer, and most importantly, it seriously cuts down the chances of the cancer ever coming back in that same spot. And you can see that playbook in action right here. The treatment is totally matched to the scenario. So if you have an emergency, like a tumor that's causing a blockage and a fever, that's a crisis. The response is an emergency surgery called a Hartmann's procedure to just get things under control. But what if you have a locally advanced rectal cancer? That's when you'd use that neoadjuvant therapy we just talked about. Shrink it first. Then there are high-risk genetic conditions like FAP. In that case, the best move is often preventative. Remove the entire colon. And for something like anal squamous cell carcinoma, which responds really well to radiation, the primary treatment is actually chemoradiotherapy. You might avoid major surgery altogether. See? 4 different situations, 4 completely different game plans.
Now, when we talk about surgery for rectal cancer specifically, there's one technique that has been an absolute game changer for patients: total mesorectal excision, or TME. It's an incredibly meticulous procedure. The surgeon doesn't just take out the tumor, they remove the whole package it's sitting in, all the surrounding fatty tissue and lymph nodes. Getting all of that out in one clean piece is what's so crucial for stopping the cancer from returning. But the journey isn't over once treatment is done. Not at all. The next phase is just as important. It's all about understanding future risk, long-term monitoring, and being vigilant to make sure it stays gone for good.
So who is at a higher risk? Well, we know that certain inflammatory bowel diseases like ulcerative colitis and Crohn's disease can be premalignant. And then there are inherited conditions like FAP, which can cause hundreds or even thousands of polyps. That just skyrockets the risk. All of this really hammers home one point. Knowing your family's medical history is absolutely critical.
And just to put a real number on that risk, let's talk about ulcerative colitis. If you've had it for 20 years, your risk of it developing into cancer jumps to between 10 and 15%. Think about that. That is not a small number. That is a significant risk, and it's exactly why regular, ongoing screening for these folks is just non-negotiable.
Okay, so after treatment, surveillance is everything. Now, because of how the colon's blood supply works, it drains right to the liver through what's called the portal system. The liver is the #1 spot for this cancer to spread. So doctors watch it closely. But you also have to keep an eye on the original spot, right? And that's why follow-up colonoscopies are a vital part of that long-term game plan.
So after going through all of that, from symptom to solution, what's the big takeaway? It really boils down to this. Awareness and understanding are the most powerful tools we have, period. Just knowing the signs to look for and knowing that there's a clear process for dealing with it, that's half the battle right there.
Look, we've seen that the playbook to fight this disease is clear. It's organized, it's advanced, and it's effective. The path forward exists. So really, the only question left is the one that started this whole journey in the first place. Will we listen to those first signs?